Okay, well, thank you very much. I hope this isn't too long, leaving plenty of time for questions. Um, these are my disclosures. Um, let's talk first, since I'm doing older and younger, about migraine over the lifespan. And what you can see with these is how, well, migraine is a disorder, is a disease of, patients peaking in the 30s and 40s. It's really quite prevalent when you look at these numbers in older age and in younger age. So this doesn't go down to the young children, 5 and so forth, but you can see that at between 12 and 17, it's almost even between males and females, boys and girls. And after the 60s, there's still 5% of women and 1.6% of men still have migraine, although the numbers have come down considerably. And when you look at probable migraine, which really acts like migraine, it just has a few less symptoms. That too comes down, but not quite as much. And the ratio of men to women is a little closer to 1. And what this is telling us, this is kind of a backhanded way, is that as you get older, you tend to get more symptoms of migraine. I mean, you tend to lose a few symptoms of migraine. This isn't always true, but many people will have less nausea or less light sound sensitivity and fewer other symptoms of migraine in their older years. But many will continue to carry their disease on into older ages, unfortunately. So there's a feeling in among headache doctors that the first thing you do is you worry about something else, a secondary headache. You don't want to treat somebody for a decade or two with, for migraine or tension headache or cluster headache, and then find out, they have a tumor or something like that. So, and what makes us think about this? It's the snoot mnemonic. And one of the things I want to point out, and this is just sort of a little useful tool for headache doctors and for generalists too, to think about when we need to get a CAT scan or an MRI, when we need to stop and reassess. And one of those things, and you can read them, is older. It's kind of unusual for migraine to progress or to start anew when somebody is over 50. So we do recognize that the ratios of simple migraine to something else begin to change, and we'd better be careful if something is a little bit fishy in an older person. So what are some of the areas of special interest in older people? Let's talk about primary headache disorders. So all of these can occur at any age, and but these are much more common in older folks. One of them is aura without headache. So most of the time when somebody has a migraine aura, it's followed by a headache. So let me step back and define what a migraine aura is. A migraine is a neurologic symptom. It's most commonly visual, and the second most common is a sensory. And it typically lasts about 10 to 60 minutes, and it gradually spreads or changes over time. With a visual aura, there could be a jagged line and a kind of loss of vision, and the line or the shape get larger, and it spreads over an area of your vision, eventually blocking out a lot of your vision. Usually up to half of your vision on one side or the other could be temporarily lost. Resolves within an hour, and many people, and many of you in the audience, I'm sure, get this, and sometimes pretty often. And most of the time in people under 50, that aura is followed by a migraine headache or some kind of headache. But in older folks, it's more likely, or it becomes more likely, that the aura will occur and no headache to follow. So it's just something to be aware of, that this happens, and it's generally not a really big deal. More interesting are what are called migraine equivalents of the elderly. And this is a major cause of people being worked up for having a stroke. So that, well, there may be a loss of vision, there can be a loss of language, there can be weakness on one side, or there can be any of a host of other symptoms, dizziness, but it can resemble a stroke. It may not have that much headache that accompanies it, or even any at all. And it, like a migraine attack, it is a migraine attack. It keeps happening. So, somebody will have one of these and they'll get evaluated and they'll be in the ER, and then they'll have another one and another one. It's simply a matter of recognizing that it's a migraine and giving it the specific treatment for a migraine, and not, putting oneself, or putting, in my case, my patient, in a horrible emergency room where they're treated for a migraine with, only the minimal concern for their symptoms, and making sure, because everybody's so fixated on making sure there's not a blood clot somewhere in a blood vessel leading into the brain. Another very peculiar kind of headache that this one is almost exclusively in older people is hypnic headache. One of the two types of headache that can have the name alarm clock headache. And this one is a moderate and sometimes severe headache, usually doesn't resemble a migraine at all. And it wakes people up usually every single night, after 3 or 4, and it doesn't go away until they get out of bed. They never can, it's too uncomfortable for some reason to stay in bed. And then, they've lost a couple of hours of sleep, and they can go back to sleep after that if it's, if they don't have other business in their day. And it's, in a way, it's a kind of terrible insomnia. It's insomnia with pain. It's a very specific thing, and the treatments are most unusual, and when we see this, sometimes we treat them with a cup of tea at bedtime. That is actually the best treatment, or a pill of melatonin. But, migraine treatment really doesn't work that well. Occasionally a medicine called lithium, which is used for bipolar disorder, is used to treat hypnic headache. But a very peculiar headache disorder of older people. And it's not always treatable, unfortunately. I saw, I think, an 85-year-old woman, as sharp as a tack, who came back to me and she said, Dr. Young, you didn't help me 10 years ago. Are you going to help me now? Unfortunately, she still had a hypnic headache, and I still couldn't help her. And, because she didn't respond to anything known to help hypnic headache. And then there's one last headache, which is a little bit more common in older folks, usually not in their 80s or 90s, but in their 60s. That's me. And that's called primary cough headache. And with this headache, when somebody coughs or sneezes, they get an explosive short pain, in their head, boom. Lasts usually a few seconds, sometimes it's very intense, and then it decays over about a minute, but then it's gone. And it's not much of an issue. Most of the time, I have a few of these patients when they're normal, but if they get a cold or a cough or something like that, it is awful, because you're hacking away in every single cough, not only your chest, but this 10 times worse head pain, bang, bang, bang with every cough. And usually that can be treated, and we can make them comfortable And one always has to get an MRI. There's a condition called a Chiari malformation, which is the other cause of a cough headache. But the primary cough headache happens in older folks, and there's no explanation for what happened. But in older folks, we really have to worry about a number of what's called secondary headaches. We break up the headaches into primary headache, where the headache itself is the disease in essence, and then the headache is caused by another kind of inflammation or other kind of condition. And very important not to miss is something called giant cell arteritis. And that's a disturbance, a disease of people usually in the 70s and older. Every decade, the chance of getting this just gets multiplied hugely. And there's a chronic nagging headache and a terrible sensitivity on the arteries in the head, which are inflamed, and the biopsy will show this inflammation. Unfortunately, the inflamed arteries can be inside the head, most notably leading into the eye. And it's a major cause of blindness in elderly people. So we really don't want to miss this. Anything in an older person that could even half conceivably be this, we worry about it. But it is, caught in time, it's very treatable. Another one that happens is acute angle glaucoma. There's a common type of glaucoma which really doesn't cause much headache. The eye drops to treat the open angle glaucoma or sometimes cause a little bit of brow discomfort, but that is really nothing. But the acute is a horrible pain in the eye, and the pupil gets dilated and red, and the attack can last for hours or can be permanent, and a person can lose their vision. So one really has to be on the lookout for this and doesn't want to miss it. It can be an emergency where the ophthalmologist has to do a tiny little procedure which takes away the pain and saves the vision in the eye. As one gets older, shingles can happen, in any distribution of nerves in the body, but the second most common place is on the head. And when it's on the head, usually it's in the forehead or in the eye, near the eye, and extremely painful. It's not too tricky to diagnose it. Once the rash of the shingles shows up, it's pretty clear. But some people will, have a terrible pain. They'll be going to the ER. It's awful. And then the rash shows up in 2 or 3 days. Occasionally you can get shingles, but the rash doesn't really manifest itself. And that one's really hard to diagnose. But for the most part, in shingles, it's those first couple of days before the rash, when there's really no good explanation for this sudden onset of just horrible one-sided pain, for headache doctors around the forehead or near the eye. Trigeminal neuralgia is a very distinct type of headache happening usually, after age 60. And that is a really excruciating pain. A quick jab, almost universally, somebody says electric shock or stab. It goes away in a couple of seconds. Sometimes it lingers for a minute or so, but it can happen over and over again. And there's something called a trigger zone, which is somewhere on the face or in the mouth. Any kind of, particularly a light touch, wind on the face, and then jab, the person is stabbed by this horrible pain, and sometimes a sequence of stabs. I've seen people lose 50 pounds because it's just too painful to eat. Anytime they open their mouth or move their skin or drink water, their pain is atrocious. And this, sometimes we don't find a cause. Sometimes we find a loop of a blood vessel on the trigeminal nerve deep inside, right next to the brain. And that, there's a surgical treatment for that that's usually very helpful. There's a kind of headache called cervicogenic headache or neck pain headache, where really the disease, it can be a disc or arthritis in the bone or a muscle knot or cramp, and the pain travels or radiates up in the head, usually the back of the head, around the ear, sometimes straight through to the eye. And that's usually on one side. It can be on both sides. Just like arthritis, it's just more common as you get older. And then there's lots of other bad stuff that can happen in the head in older people, just to be careful, like blood clots called hematomas, and there's several kinds of those, or tumors, which can happen to anyone but are more common in older folks. I hope that gives you a little bit of a sense of things that that are more common in older folks, and that we really have to worry about, and why we have to be extra careful in these circumstances. I want to tell you about something called the Beers list, which is, and what this slide is about is how medicines are more dangerous. They're more likely to cause serious problems in older people, which makes it harder to treat older folks. In the Beers list, more or less, their innovation was bringing, keeping track of medicines that are put people at risk for old people at risk for falls. And unfortunately, there are a lot of medicines that headache doctors use that are on the Beers list, particularly for falls. And it's updated every year or two, and it's a great resource. So you might, if you or a family member, thinks that there might be side effects, you have some concerns, you can just Google Beers list and find the most recent one and go through the meds and see, because it's on the Beers list, that doesn't mean that the patient should never be on it. But it's a risk-benefit calculation. And the thing is, with older folks, they may seem to be, tolerating the amitriptyline just fine. They will record no side effects from the amitriptyline when I, the doctor, ask them. But I know that nonetheless, they're more likely to fall, even if they think they're fine on the amitriptyline, than many other medicines. And so if it's working well for them and they want to stay on it, but I don't want to hear that they broke a hip, we get a little bit of back and forth there sometimes as this difficult decision gets made about what we're going to do about their medicine that's helping them as they get older. This is just one way to break up the medicines we use. And what the issues are for the older folks. These are the major categories of migraine medicines. They're the triptans and the ergots like sumatriptan or DHE or lasmiditan. Lasmiditan, not so much the heart, but everything else in that column, we worry about heart disease that's silently there in an older person, and we're a little bit concerned about prescribing those medicines. With the non-steroidal ones, like Motrin, ibuprofen, naproxen, Metzaleve, and we use so many of them in headache medicine. There really is a risk for the kidneys, and it's particularly a bigger risk in older folks, much more so in older folks. great medicines for migraine, the nausea medicines, the old school ones, compazine, I'm going to say the more common names you might have heard of, Reglan, Phenergan, Thorazine, Haldol, Zyprexa. You can read them here. These all put older people at risk. And the GPANs are great. Ubrelvy, Nurtec, they really have almost no side effects. They really don't put the older patients at risk, for their heart or kidneys or falls. They just cost a heck of a lot. And the Medicare is horrendous with the copays, and they really get punished for taking what's probably the safest medicine for them if it works. And then there's the medicines, the opioids and butalbital, which are habit forming, and one needs to be careful with that at any age, but in the elderly, they're very much putting folks at risk for falls. So these are all the issues that we deal with in an aging patient with migraine and trying to use the standard migraine medicines. And then there are the migraine preventives. The CGRP preventives, I've listed those. I'll give you their names: Aimovig, Emgality, Ajovy, Vyepti, Nurtec, and Qulipta. And I put dollar signs next to the Nurtec and Qulipta because there the Medicare patient really gets screwed again by the system and no help with the copays, and a system that stacks that against them. The anti-seizure medicines, by and large, are putting older folks at risk for falls, and amitriptyline and nortriptyline put older folks at risk for falls as well. Blood pressure medicines, again, they're fine, but if you overdo it a little bit, and as an older person becomes more sensitive, they become at risk for falls, as does the cyproheptadine. And then the botulinum toxin, which is only for chronic migraine, is a pretty good choice because it has, really very few side effects that are in any way dangerous or worrisome for a person with an older person with migraine. And the copay system with Medicare is not so terrible as it is with the with the Nurtec and the Qulipta. So these are the major migraine preventives and how things stack up in older patients who have migraine. What about devices? Everybody has to pay for their devices. I don't know. I guess I'd perhaps Dr. White can comment. I think that that the older folks, they don't quite, in my experience, work as well. I don't think I've ever seen that described, but sometimes on a fixed income cost is an issue, but they're certainly safe. The really nice thing about all of these devices is it's almost unimaginable that you would cause a serious adverse event with any of them. So that's very nice. Let's talk about headache in the young, and I'm not a pediatric headache specialist, and I can't go too much in detail, but I just thought I'd talk a little bit about this. So there are, of course, the primary headaches, of which migraine is the most common. And just one thing I want to point out is that in kids, migraine is often a much shorter attack. Some of them can get the whole thing from, pale to pain and nausea and vomiting and sleep, and wake up in 2 hours and the whole storm has passed. Boom. It takes much longer in a grown-up. And then kids have, some particular variants that they're much more likely to have. They have true hemiplegic migraine, not the kind that most adults have, but the kind that comes from a gene, a specific gene, and runs in families and generally hits when you're about 12 or 13, and really looks like a stroke, and then it passes. And so that's a kind of migraine that's much more common, because that true genetic hemiplegic migraine tends to go away in adults, and most people lose it in their 20s. And then they have a particular kind of migraine with brainstem aura in adolescents and sometimes younger kids that really is can look like a coma with dizziness and vertigo, when they're a little bit less out of it. And that's migraine with brainstem aura or Bickerstaff's. And then there are these sort of special conditions. Did you know that infantile colic is being thought of now as the first throw of migraine? And if a baby has colic, they may be much more likely to get migraine later in their life. And either it's a foreshadowing or it is a type of migraine. It's a little bit unclear because they really can't be clear about their symptoms, but that's infantile colic, a couple of months old. And then in the 3, 4, and 5-year-old, these two conditions where these kids will have episodes where they'll get their head all twisty and their neck will be in a peculiar position, and they're wandering around a little bit uncomfortable and like this. And it's a kind of migraine, this paroxysmal torticollis, as is this sudden short vertigo that young kids can get, which turns out is really in the migraine spectrum. And then when the kids get a little bit older, coming around, 9, 10, 11, they can get cyclical vomiting or abdominal migraine. And cyclical vomiting, I've sometimes seen this in adults, but it's much more common in kids. It can be weeks or days, 4 or 5 days of unexplained vomiting, often without any pain or explanation. And then it passes. And then, a month or 2 or 3 or 6 months later, we get another episode. It turns out it seems to be a kind of migraine. And then abdominal migraine, the pain is not in the head, but in and near the belly button. It lasts hours and then it passes. It's very uncomfortable and no explanation. And the kid and the parent are beside themselves, and then it passes, but like a migraine, it happens again and again and again. A big problem, and a source of confusion, and these can be hard to treat. And then kids, they can get hydrocephalus, which is sort of water on the brain, a backup and a high pressure of fluid because of the lack of fluid of drainage of the spinal fluid, or brain tumors, presenting as headaches. So things to worry about with children. And migraine treatment, unfortunately, kids don't respond as well to treatment as adults. It's just harder. And there's some evidence for topiramate and propranolol and maybe amitriptyline with cognitive behavioral therapy, but not amitriptyline alone. And Botox was not effective in a clinical trial, and the clinical trials on the CGRP medicines haven't come out. Doctors trying to help these kids have fewer tools. The Zomig, and some of the triptans may work, and the NSAIDs have been shown to work. But compared to that, those longer lists of headache medicines that work in grown-ups, the things that are available for kids are not as much and not as good, unfortunately. Um, Now, I didn't talk about the devices, but, and this is a little bit, I'm going into speculation, but my sense is that devices actually work a little bit better in kids. And wouldn't it be a good world where if you get migraine as a kid, one of the main job at first is to figure out how your nervous system works and which type of nerve stimulation settles down your migraine, your misbehaving migraine network better, which neuromodulator modulates your migraine in a better way. And then that information will be helpful for you for your whole life. So, that's a perfect world. These things are expensive. The gamma core is the one that has, which is the one that stimulates the vagal nerve, is the one that has the evidence in kids. The other ones really don't have quite the evidence in kids that the gamma core device has. My suspicion is that, it's a good time to find out which device works for which kid, and they can use it for the rest of their life. And I know we've been babbling on a little bit, so I'm going to try to I can't do justice to new daily persistent headache, but I do want the folks on this call who don't know what this is like to understand, what it is. It's a continuous and unremitting headache that begins in less than a day. So imagine, you only had occasional tension headache, no problem, and one day you wake up with a terrible headache, and there's not a moment of relief from that point on. And it goes on for more than 3 months. So if somebody's only had it for 2 months and you don't know, it's a disease that doesn't have a name. Don't get me started complaining about the classification. And the headache itself usually is indistinguishable from either migraine or tension headache. And somebody who has migraine or tension headache is unfortunately not protected from getting new daily persistent headache. But we sort of have decided that they really can't have a period of escalation. If you have migraine and then over a few weeks or months, it becomes very much more frequent and eventually becomes daily and continuous, that's not new daily persistent headache. Almost universally, a person can name the exact day that it started. It started on September 3rd, and they'll tell you the year. Most of the time, unfortunately, one cannot find a precipitant or a cause. The most common one, if you can find something that kind of makes sense, is they had some kind of illness. And if you think about COVID, there is new daily persistent headache that follows COVID sometimes. Usually, the headache goes away, but if it doesn't, it fits the definition of new daily persistent headache. The headache, unfortunately, there isn't anything that is specific that helps you. There's no universal treatment for new daily persistent headache, and we're limited to treating. If it looks like tension headache, we treat it like that. If it looks like migraine, we treat it like that. And that's not something else. And I'll go through what the something else might be. But, obviously, when somebody gets this kind of headache or presents this way, you're going to be extra careful not to miss an important fixable thing that might straighten out and stop this headache. And they are notoriously tough to treat. And I saw a poll of headache doctors, and what is the headache that you find the least pleasurable to take care of, and it's new daily persistent headache is what headache doctors have chosen. I probably shouldn't say that, but it's tougher to treat than chronic migraine in general, or, and there's another piece, which is, the patient who has it is often really upset. The person with migraine where it changed and evolved, often has had a time to sort of accommodate to the pain and the disability in some kind of sense. And I've seen, hundreds of new daily persistent headache patients. It actually takes them years to get behind, like, but what's the cause? What happened to me on September 3rd? Why is this happening to me? And they can't get over that, and they can't be satisfied to the place where they can settle down and find the best treatment that they can, without always having to look and look for the most wackiest specialist who, wastes a lot of time and money on them, unfortunately. But there are certain things we think about. We think about infections, particularly Lyme disease and fungal infections of the brain and of the spinal fluid, post-infection, anything. A blood clot in the veins around the brain, a spinal fluid leak, a high spinal fluid pressure can start, or a headache called hemicrania continua, which is treatable with a medicine called indomethacin. It's always on one side. And so there's kind of a debate among headache experts. Some people saying, well, it is obviously always a secondary headache caused by something, and we're just not smart enough to know what it was, but it's a secondary headache. And then there's the others who say, no, it makes more sense to treat it like a primary headache. It happens often enough that there's no known cause. It is a thing, and you just, put it in that category of new daily, and you treat it like that. Because as soon as you find out, oh, it's a spinal fluid leak, or it's a high pressure, it's no longer new daily persistent headache. It leaves that category and goes into another category. So that is, I've rambled for probably way too long, and I hope this is useful or helpful for people. Thank you for your attention, and that's what I have to say. Thanks.
Thank you. That's some new information for me. So thank you very much. There's a few questions. I'm going to ask you three. One thing, what do you define as elderly? You gave some ages for some of the things, but like, do you have an overall age when you say elderly?
The medicine does not have a good definition for elderly. Dr. White helped me out. For the purposes of SNOOP, when you are more likely to get it's over 50, which is outrageous to me. But that's for the SNOOP. For other specific types of headache, it's usually in the 60s and 70s.
Okay.
I think, with other, neurological conditions as well, I think kind of that 60 to 70 range is probably kind of that transition into elderly, I would say.
Okay, wonderful. Another question is, for those of us that have chronic migraine, is there a greater likelihood of developing a second type of primary headache as we age?
Wow. I certainly see it on occasion. I've seen switches, from migraine to cluster, for example. I don't think it's greater as we age, though. I just think, they happen occasionally at any age. But that is a thought-provoking question.
Okay, we'll follow up with you on that one then. Okay, the last question we're going to ask is, can adults also get abdominal migraine?
Yes.
Yes, okay.
Yes. Classically it's in kids. It's less common in adults, but certainly, yes.
Right, here's one that someone just dropped in real quick. Do genetics play a part in the new daily persistent headache, do we think?
I don't, there are not enough of them that there have been good genetic studies. And my guess is no, or less than migraine, but I don't think there have been genetic studies as there have been in migraine.
Okay. Wonderful. Well, great. Well, thank you very much.